to use interventions that are going to treat the pain. And the best way is by a multi-model approach. Because this way, if we use several medications across the spectrum, most of the time as a result of using medications that use different mechanisms, we don't have to use high doses of any of them. And if you don't use high doses, then you have less side effects, you have less issues with addiction, so and you don't have to have, the dose is much lower. So it's a lot more tolerable that way. The main being that even though we get low doses and we get low side effects, we get greater results because pain management is better. Aspirin and acetaminophen, as I said, are some of the front line for the non-opioid. Aspirin, you always have to be watching out for side effects such as bleeding and GI issues. Acetaminophen, it doesn't have the bleeding issues, but it has the risk of liver toxicity. So you always want to be on the assessment to make sure you're assessing the patient for whatever's going on with them on the medication they're taking. The next level are the opioid, Morphemes, ibuprofen, Oxycodone. And if you are moving to this level, it means because the first level did not work, and then you're adding. But whatever non-opioid you gave, you're still going to give with the opioid. You're going to give both of them. You're stacking it up to figure out what works best to give them the pain control. And then the last level is the adjuvant analgesics. These are local local anesthesics. They're also anticonvulsants, antidepressants. These work best for neuropathic pain because that is more of an abnormal pain response, and these medications work best with that. Sometimes you have to go all three levels. The World Health Organization established the pain relief ladder, and it kind of works the same way with the pain management model that I just gave you. You give the non-opioids first, then you progress to the weaker opioids. That doesn't work, you go to the stronger, and if that doesn't work, then you go to adjuvant. So it's a stepping ladder. The fourth level on that that's really not shown is the nerve blocks, epidurals, those sorts of measures for very severe chronic pain, cancer pain. So chronic pain is long-lasting. You use a long-lasting analgesic, and then you also have a short-acting that you use for breakthrough pain. Preferred route is, I'm coming from a hospice background. We don't do injections in hospice unless we have to. So PO is preferred if that works. But when you first have pain, sometimes you have to do the IV route first to get that managed, get that controlled, figure out where you need to be, and then you'll switch over to PO. How do you think the PO and the IV dosage works? It's going to be the same? No. Your PO dose is going to be what? Higher or lower? It's going to be higher because whenever you take medication, PO, it's got to go through your body, through all these systems. It goes to your liver and gets broken down, so you get less medication that's actually available in your body for PO route to apply to that pain. So IV works fast, right? Right there. Lower dose, but whenever you're making that transition over to PO, the dose is going to go higher. Okay, and there's actually charts that are available that and if you check in your book, there's a chart in your book as well, that if you're taking IV dose this amount, then the PO dose would need to be here. And it's really important to make sure that that's an equitable dose. You wouldn't just think that the same IV dose is gonna work PO. Another analgesic ladder of how to treat. The non-opioids are for mild to moderate pain, and you will add the opioids if it is for more intense pain. The non-opioid have antipyretic effect, they have an anti-inflammatory property, and one thing, as I mentioned about acetaminophen, make sure you watch for liver toxicity. They shouldn't be taking more than 4 grams of acetaminophen a day. It's safe to give them concurrently. Opioids are for moderate to severe pain. We don't give nepiridine anymore because, especially in older people, because of the seizure side effects. But other side effects are constipation, orthostatic hypotension, urinary retention, nausea and vomiting, sedation, respiratory depression. What does that put our patients who are on these medications at risk for? If they are having orthostatic hypotension, what's going to happen? Fall. And what happens in a fall, especially in an older person?
Hips break.
They get a broken hip, so our treatment didn't do them so well, did it? So we always have to make sure that no matter what we're doing, that we are giving them, keeping them safe, assessing them. If they are, if a patient's having sedation, that is significant. It's not something that you're going to ignore. So you're always going to be assessing your patient for sedation, because sedation in the spectrum of the opioids, sedation is going to become before respiratory depression. It takes less medicine, it takes less dosage to make sedation than it does respiratory depression. So if your patient is exhibiting sedation, lethargy, hard to wake up, that's telling you right there that the dose needs to be pulled back before it gets to respiratory depression, okay? So always be gauging that by the sedation. The adjuvant is anticoagulants, anti-anxiety. Why do you think the anti-anxiety helps with pain? The more anxious someone is, thinking about it, they're anxious, and it just gets your system going, right? And then it's harder to maintain, it's really hard to get pain down once it's a certain level. That was the hardest thing in hospice, getting patients and their families to understand, because of lots of reasons people don't want to take pain medication, right? So they'll, I'll hold off until I have to. Well, that's the absolute worst thing to do, because once you get severe pain, it is so hard to bring that back down. It takes so much more medication, whereas if you just keep it, treating it so it's not going up, you're 1,000 times better off. That is one thing that's really hard to get people to understand, and that's really important for patient teaching, that you have to keep that pain level down in order to manage it better. And it actually ends up using less medication dosage than if you hold off to the last minute. Opioids work in the brain. Local anesthetics work in the spinal column, and are also at the very local site. So in assessing pain, we need to assess frequently. It is considered the 5th vital sign. So anytime you're interacting with your patient, you're going to be asking them their comfort, pain level. You're also going to reassess that often. You shouldn't just ask that at the beginning of the shift and not ask them again. You're also going to reassess after you have done an intervention. You know, so you need to always reassess to see if your intervention has been effective. So asking a patient about their comfort level and their pain is something you're gonna do multiple times a day, because we want our patients to have good pain control. The gold standard is ask them how their pain is. You are not a judge of their pain. Some people can be in great pain and you'll never know it. Other people show them. What you think impacts how a person communicates their pain? What are some things that you think that will impact that? Their culture, their past experience. If you were have been, you know, if you're a person who's verbalized pain and been made fun of it, oh, you're just a weakie. Military does that, right? Any of you been in the military? No one wants to ever show weakness, right? My dad was Army, my husband's Air Force, so, you know, you always put up this strong front, and you don't ever want to show weakness, but, so some people you'll never know that they have a pain. You'll never know the battle that they're facing inside because of the front. So, and when we assess pain, we're gonna ask them, we're gonna use their words to describe it. Whenever you are documenting, you're gonna use their words, not your words. They report this. You wanna know the intensity, the location, the duration, what relieves it, what aggravates it. And don't forget referred pain. Because the patient might be having pain in one place, right? Their left arm, but that's not the problem, correct? What's the problem? Cardiac. So don't forget, whenever they're reporting about referred pain. And another part of assessing pain is about how does it affect their life? When we have patients in the hospital, you are their life. That's kind of what you guys are thinking about if you're in an acute setting. It's all about taking care of them in that moment, correct? But as a community nurse, I know how it affects their life, their family, how they're living, because I'm in their home and see those sorts of things. So whenever you're assessing pain, and it's been chronic or even acute, what can you not do now that you used to be able to do? What did you used to do? So that's very important because that's where they live, because that patient is seeing how their life has changed. And how their life has changed impacts their feeling of, can I ever get over this? Can this be managed? Can I get my life back, right? So in acute setting, I'm always cautioning professionals to think outside the box of the acute setting. This patient's gonna go home. I used to get discharge orders from from hospitals as a home health nurse, and I would open them up and it's like, oh my goodness. No one assessed this patient for what their life is like here. Because I've had patients at home that had very involved dressing changes, and they didn't even have, they had a dirt floor. Or they didn't have running water. Or their caregiver was a 38-year-old developmentally challenged child. And they have these beautiful discharge orders. Oh man, they would have won an award, but they had nothing to do with that person and what they were coming home to and what they were going to have to live their life with. So always be thinking outside the hospital box. You're there in that moment, take care of things, but pain is huge. It disables our lives in so many ways. Anybody got any questions so far? And using their words, tell me how to describe your pain. 0 being no pain, 10 being worse. How does it affect your sleep? If you're in pain and you can't sleep, Do you think that adds to your pain? It adds to it, makes it worse, makes it harder to deal with. And ask them, are they having any other symptoms? Don't just focus on the pain. Remember, the pain is just a red flag that something's going on. And we need to investigate to see what other things are happening as well. Check vital signs. If someone's having acute pain, their heart rate's going to go up, the respiration rate's going to go up, blood pressure, they're going to be diaphoretic, pale, but not always. Especially if they're chronic. If they've kind of got used that, yeah, this is what I live with, those vital signs are not going to be elevated. In fact, they kind of, if they get depressive about it, that stuff can go down. So if someone tells you they have a pain level of 8 and their vitals are like way down, don't be judgmental about, well, they're not telling me the truth. It may be that they're just accommodating what they've been living with for a while. So people that are unable to communicate are at the greatest risk for experiencing poor pain management. So behavioral signs, if the person can't say these words to you, facial expressions, restlessness, change in activity, crying, grimacing, irritable, agitated, combative, especially in a cognitive impaired patient. They're going to be combative if they're in pain. Do you know what the most painful procedure in the ICU is? The most painful procedure you can do in the ICU. Turn a patient. And how often do we turn a patient?
Every 1 to 2 years.
That's been reported as, hands down, the most painful thing you put your patients through in the ICU is having to move them. That's not even, I mean, it's connected, but it's not connected to their pain, right? They're laying there in pain, dealing with their pain, and oh, let's add to it, right? But it's something we have to do, because if we don't do it, what are we doing? We're going to add to otherwise. But be aware when you are doing these procedures that we don't think anything about. We've been, you turned everybody on the floor, but just think that is reported as the most painful procedure. So pre-medicate patients before you do procedures on them. Pediatric pain descriptions. Pediatrics is a unique area because some of our ped patients are very expressive, right? You know exactly how they feel, right? But then lots of times they may be reacting in a way that they can't really express to you what is going on with them. And they may use different words. They may say owie or boo-boo or they feel bad. You have to listen to their words and try to interpret what they mean by those words, because pediatric patients aren't really good until about the age of 7 of expressing their pain. They are still a reliable source to ask if they're in pain. They can tell you that something's going on. They may not be able to tell you exactly all the details, but they are still able to tell you if they're uncomfortable. So they should always be asked. Don't ever think that you shouldn't listen to the child. Doesn't matter what age they are, you need to ask them. They may be screaming, they may be grimacing, they may be kicking their legs, drawing their legs up, they be arched, rigid. Look at their position. Are they guarding a certain area of their body? Lots of pain scales that we use in the healthcare setting. Pain is subjective. The Wong-Baker face rating scale can be used by a child that's 3 years old. It can also be used for a cognitively impaired adult as well. They can look at the scale and tell you where they are on that. Ranges from neutral phases of no pain to crying. Also, there is a face pain scale for children. It's a little more involved. The flax scale is used for children under 3 or with a cognitively impaired person who can't communicate at all. You're looking at their face, their legs, what kind of activity they have, are they crying, how consolable are they? So this is another way of measuring pain. We are going to assess pain at regular intervals. We're going to ask the patient to establish a comfortable functional goal. We cannot always take away all the pain, correct? But we don't need to leave them in the land of deal with it. We need to find a happy medium to say, okay, where do you think, what's your goal of getting your pain level to that you think you can function? So it may be a 2, or maybe a 3, that, oh, if you can just get my pain to a 2 or 3, that will be comfortable enough for me to do my activities or to have, engage in my life. So we can't always take away all the pain, but we need to involve the patient in the process of saying, where do you want to be to function? Because we may be, yeah, I can take away all your pain, I can make you unconscious, correct? But is that where they want to be? Make me in a stupor so that I can't have a life? So we have to gauge what we can do for them and what they can tolerate to get to their goals. It's all about their goals, not ours. So that's very important for them, work with them to set that goal of what their pain level should be. Big thing is to discuss their fear of undertreatment, their fear of overdose, or their fear of addiction. I will never forget my first job as a nurse. I was taking care of I think she was like 40 years old lady with ALS. And her legs, it was just awful to watch her because her body would get so contorted with muscle cramping and drawing up. And we actually would, it was just awful to watch. And she would never take pain medicine. And I took care of her for a couple of days, and it's like, you have pain medicine ordered, and muscle relaxants ordered. Why don't you take these? And her comment to me was, it's bad enough that I'm dying in this way. I'm not going to die an addict too. That is terrible. That someone had made her think that if you take pain medicine, you're going to be an addict. She was in agony. But someone had made a flippant comment to her. And we don't know how those flippant little comments affect people. So she was in agony. And it took weeks of coaxing to get her to take something and assure her, this isn't about you being an addict or dying an addict. She lost all her control. She was 40 years old in long-term care, or in a rehab long-term care facility. She didn't have much left of her life. And she was going to hold on, I'm not going to be an addict. So be careful how we talk to people. Another example is, people don't want to lose that control. My dad, bless his soul, was a military man. He was actually a frontline medic, always on a nurse, listening to him. But he was a POW in the Korean War. And terrible experience for him, as you might imagine. So when he got cancer about 9 years ago, and he was in the hospital, they gave him one night Ambien to help him. My little dad is a little guy, reserved, quiet, precious, sweet as he could be. Very kind man, he was a minister. Well, he stripped off his clothes ran up and down the hallways for 3 hours, 4 hours that night with no stitch of clothes on. Thought he was back in the military, being in, in his POW camp. My mom, my brother, they were all there trying to calm him down, could not reach him, he was in the camp. Well, the next morning when he woke up, he was so humiliated after he heard what happened. He never took another pain medication. He never took another anything. He died in agony because he did not want to be embarrassed. He didn't want to risk that and have that memory. So think of your patients, okay? Always anticipate the need for pain medicine. Eliminate any stressors. They have other things going on. It's going to be harder to manage their pain. In the hospice situation, we treat the family because that's where that person is in that family, and you have to get things set up for their stressors to go down, to manage that, help them manage their pain. And most of the time, families that are in hospice care are a mess, right? They're losing their loved one. Lots of family fights are going on. Trust me, I've seen some knockdown, drag out ones, a hospice situation. So always think about the other stressors that's going on that's going to complicate things. Determine the right and appropriate pain relief. It's individualized for everybody. Some people are going to take the medication. Some people are going to not take the medication. And sometimes it's a balance between. I had a military guy who was a Marine that had bone cancer. And they called me to the house one day because he had got out of pain control. He lived up on a hill. One of these people had to kind of walk to get to their house, the Appalachian Mountains. And when I pulled my car in, and he lived on a little trailer up on a hill, when I parked my car down below, I could hear him screaming. Screaming. This was a Marine, tough as nails Marine, screaming, but you could hear him. So I go up, he had all of his pain medicine, nothing was working, couldn't touch him, couldn't stand sheet to touch him, he was out of control. I didn't know what else to do for him. So I heated up a bottle of lotion, and I started rubbing the bottoms of his feet. It was the only thing that he could stand to be touched, bottom of his feet. 30 minutes later, when I left, he was asleep. I hadn't given him any pain medicine. I didn't give him anything else. But sometimes those things work. So look for that. You have to look for ways to give them pain management, give them comfort, okay? And in that case, just to try to calm him down, I just started bottoms of his feet, all I could touch. But got him down and allowed the other medicine that was in him to work, just because it got him down. So it's individualized. Figure it out. And you have to investigate. You have to take time. Always give medication as ordered and evaluate, see if it needs to be adjusted. Because sometimes it needs adjusting. Sometimes what worked for other people does not work for this person. And if it's not working, make sure you call the healthcare provider. Let them know it's not working, or let them know if there's a significant change. So pediatric considerations, if they're in the hospital, try to keep their room as a safe place. They're already in a weird, they're already upset because they're not home. So don't do, if you can prevent it, don't do procedures in the room. Take them to a procedure room so that that's where that happens, and then they come back to their safe room, okay? Keep them medicated appropriately, observe them. Don't let, just because a child's not telling you they're in pain, it doesn't mean that they are not. Actually, children and neonates, they have discovered, feel pain more acutely than adults. So even though they don't communicate it, it's there, and medicate it and treat it appropriately. Another thing is, don't ask a parent to restrain a child. Get other staff for that. The parent should be their safe person, their support person, the person they run to for to be comforted. That parent in a terrible situation if you're having the parent hold them down while you're doing something painful. That, who's gonna comfort the child then when they don't trust their parent, right? So get other staff members to help with that sort of stuff. So, the non-pharmacology strategies, they complement our, medications that we give, such as I was talking about massage, we have acupuncture, we have heat and cold application, we have distraction, which works really well with children, and just because you can distract them does not mean they're not in pain. It's just techniques to help take their mind off of it, it doesn't mean they're not in pain if you can distract someone. Music therapy, pet therapy, herbs, vitamins, all kinds of things that can help pain management. Children like to have sometimes a security blanket, a stuffed animal, pacifier, whatever they need for comfort and security. Encourage that. Sometimes just the proper aligning someone in bed, or a good change of sheets, a bed bath, all those sorts of things can, just changing the bed, getting rid of the wrinkles and that sort of stuff. Sometimes just little things like that can make a huge difference with a patient's comfort. But we should always be regularly changing their position, helping support them with pillows, using heat and cold therapy. All those things are added to medication. Risk factors for under pain management is what the society cultural attitudes are, what the attitude of the health professional is. If you're already making judgments about your patient, then you're not going to be very effective in helping them manage their pain. Sometimes the lack of knowledge, like I was talking about the young lady who thought that she was going to be an addict if she took anything. You need to educate them. They have a fear of addiction. Lots of people have a great fear of addiction. We need to explore that with them. Or they have the exaggerated fear that I'm going to have respiratory depression and die if I take that. There's a huge difference between the therapeutic level and respiratory depression level. So we need to educate parents and patients on that. Always, always, always though, when you're dealing with opioids, be assessing them for sedation and respiratory depression. Always evaluate, what did I do? Was the intervention, is it working? Is it not working? Always figure out ways to add to that. Safety, safety, safety. Patients are taking these pain medications. They are great risk for injury, falls. Make sure that we are monitoring them. Might have to have the side rails up, the bed monitors on, have somebody with them, check on them more often. Okay? Any questions? Everybody feel a little more comfortable now that you've been watching all this beach for a while? I'm ready to go there, right? So, this is my first day with you, so I really don't have a feel for what you guys do. How many of you are presently working like acute care setting? Work acute care. How many of you are working in a clinic or lots of clinic type setting? Long-term care? Of those of you that are long-term care, are you doing hands-on care or are you doing administrative? Hands-on? I have great respect for long-term care. I started out, that's how I worked my way through nursing school, was as a nursing assistant in long-term care facilities. So I know the hard work you're doing, and I know how much harder COVID has made that hard work, and how awful it is without families being able to come in and see their loved ones. So that is definitely an added piece to that. So definitely have my about acute pain? Talked about pain in general, this concept, the scope of it. Acute pain, as we said, it's protective, short-lived. You can usually calm a patient down a little bit, just by saying it's only gonna hurt for a minute, right? Isn't that what they even tell you whenever they're gonna do a painful procedure? You're just gonna feel pain for just a minute. We wanna know how long it's gonna last, don't we? That helps us deal with it, correct? If it's great pain that's gonna last 30 seconds and then I'm gonna feel all better, that's a whole lot of difference, right? So the length of the pain, the intensity, all very important. So acute and chronic pain differ in their cause. Acute pain, we usually can figure out what's going on, what caused it, so we can relieve it. It's, acute's also a little different in its manifestation. You have that increase in the vital signs quickly. We also, different treatment, because we can, if we know what caused that pain, then we can take it away pretty quickly, right? Or at least to the point where they can be healed. So acute pain has sudden onset. 25 million people each year suffer from acute pain due to injury or surgery. Duration is less than 3 months. Usually by the time they're healed, the pain's gone. Only for a little while. Can be moderate to severe. There can be an illness or a surgery or trauma, something that we know that we can trace back to know what caused it. The course of pain decreases over time. Usually, acute pain is most severe when it first starts. And then, as your body's healing, it's going down. So usually that acute's really intense, and then it gets better when we are treating it. So you have an increased heart rate, increased respiratory rate, increased blood pressure, pale, diaphoretic, anxious, maybe confused, may have urine retention. It also increases their cardiac output. It also increases their myocardial oxygen consumption. It increases their coagulation because our body's in that fight and flight, right? Let's take care of this problem. So one of the big pains is renal calculi. Kidney stone. How many of you have anybody in here ever had a kidney stone or seen someone who had one? They are pretty miserable people, right? Miserable. Great intense pain quickly. That's the first thing people complain about. And the intense pain, sudden pain, called renal colic. Due to the stretching or the distension or the spasm of the ureter. The pain's all, you have pain when what's happening with the renal stuff, with the kidney stone. When the stone is on the move, you are in pain. When it's still, the pain's down a little bit. It may still be there, but when the kidney stone is on the move is when the pain, because why? What's that stone doing when it's moving? It's tearing up whatever it's touching, right? Most are calcium salts, uric acid, magnesium, ammonia. Most of them originate in the kidney and then travel through the urethra to the bladder. As I said, the chief complaint is pain. The location of the pain gives you a clue as to where it is. Treatment, we're all about reducing the pain and passing the stone, correct? Not going to fix it much until that stone gets passed. Encouraging ambulation, giving them opioid analgesics. They have intense pain. And Tylenol is not going to help this, okay? Intense pain. Usually you're giving IV medicine in the emergency room. 13% of men, 7% of women will have a kidney stone. Increase with age. That is the one thing as a professor I've learned over and over, every time I'm talking about something bad, your risks increase with age. It makes the aging sound really bad. Oh, who has the most risk? The aged. So, does it increase with age? And if you have a stone, 50% of people who have a stone will have another stone. The incidence is higher in the southeast U.S. It's more often in the summer months. Hot climate and dehydration add to the woes. Pain is acute, as I said, flank pain, hallmark sign, radiates to the perineal, the groin, scrotum. It's sudden and unbearable. I've seen people go pale, hit their knees, and pass out. Can be intermittent, it can be continuous, it's just all about what that stone is doing. Patients are usually pale, diaphoretic, and hypotensive. They cannot be still, kind of is what you notice. They'll sit, they'll stand, they'll walk, they'll lay down, they're moving, they're very, very restless. It's called the kidney stone dance because they are just trying to find a position or something that gives them a little relief because it's such intense pain. They have a kidney stone dance. They may also have signs and symptoms of a UTI, like fever and chills, dysuria. But if they complain of a sudden sharp flank pain, lower abdomen, called renal colic. Most stones are 4 millimeters or millimeters or less, and most pass spontaneously. I say spontaneously, I did not say no pain. Most can be passed. Non-surgical approaches are analgesics until they can get it passed. So they usually need pain medication for 24 to 36 hours. Give the pain medication regularly, not on a PRN basis. The opioids, lots of times according to the pain level, are maybe given IV for rapid pain relief. Torlac is also a medication that's given. Risk for bleeding though increases. And if you use it, then they may have to hold off on the shock wave with electricity. Other management includes overhydrating or avoiding overhydrating. You want them to be well hydrated but not overhydrated. Strain the urine so that we can do what? Why do we strain the urine? We want to know what the stone was made of, so the elements of the stone, so that we can make dietary adjustments if we need. Minimally, sometimes they require surgery. You may have to have a stent, they may have to have another procedure done to get the stone out, depending on the size, depending on what's going on. Some of the non-pharmacological things to do: the warm bath if it's just moderate pain, mild pain, warm bath, warm moist heat. All depends on the size of the stone, where it's located, as to what procedures that are going to be done. But it can be anything from medication, good hydration, all the way to surgery. Just broad spectrum. But they have pain the whole way. So pain is huge. Acute pain is huge with kidney stones. Assessment. We're going to ask them how comfortable they are, we're gonna believe them. I remember working in the ER, years ago, and, a person who had kidney stones was coming in quite frequently. And I remember the comments of, oh, they've got another kidney stone and needing some pain medicine. Could be true, but I need to believe the patient. I need to manage their pain. And if someone is a drug seeker or someone has a substance abuse history, we need to treat that too. Because it doesn't matter what their abuse status is, when they are in pain, we believe them and we treat their pain effectively to manage it. We make the proper referrals to other agencies that can help with the other pieces of that, but we're not going to be judge and jury about someone else's pain. So ask them, do a pain assessment. If you're doing a procedure, you're going to anticipate that that's going to be painful because it's painful for other people. And if it's painful for other people, it's probably going to be painful for the patient you're taking care of. So you're going to medicate and treat that pain appropriately. Observe for behavioral cues that we talked about. Observe for vital sign elevation, but know that vital signs are not always reliable for reporting pain, especially if it's chronic. Check for bladder distension, indicate if they have obstruction. And pain is worse if you have other things going on, correct? So if they've got nausea and vomiting, they're having retention, all of those things are just going to add to their discomfort. So treat any associated symptoms that you can. Your nursing diagnoses. Acute pain will be the first one. Impaired comfort. The acute pain is related to the trauma and the stone. The trauma of the stone is inflicting. Impaired urinary elimination, and may be completely obstructed. Risk for fluid volume deficit. Nausea and vomiting. If they're having nausea and vomiting, or they're in too much pain, they're not going to eat anything, or drink anything, so you should encourage fluids. Talked about pain medication, the opioids, the NSAIDs, the antispasmodics. Going to hydrate them. They're going to be MPO if they're going for surgery. It's really important before they go to surgery to tell them what they are going to experience, right? So help them understand what they're going to see and hear and expect, what they expect before, during, and after the procedure. So education is still vitally important too, because having knowledge makes people less anxious, correct? And if they're less anxious, then they are going to have better control, better pain control. Pre-op care, post-op care, always going to be watching for bleeding, obstruction, infection. All those things are always part of our assessment. Pain management, we're going to have encourage fluid, ambulation, use positioning, try to find a position that they can get some relief, some moist heat, relaxation techniques, diversion. Get a feel for what we're doing. Is your pain being relieved any, or is it getting worse? Assess their pain and assess after intervention. What helped? Did it not help? Did it make it worse? Kidney stones in newborns and infants is rare. Vomiting and restlessness is the usual signs of that. Increases with adolescents. Again, same thing that adults can have, the lower back and abdominal pain. May be accompanied by nausea and vomiting. Pregnancy, as you can imagine, makes it more complicated, correct? Lots of people that do get kidney stones in pregnancy. Complications if the stone doesn't pass, may have premature labor, interruption of their progression of labor, complicates the treatment because we don't just like run them to surgery real quickly, right? So conservative management, nephroscopy for larger stones. Older adults, here we go again, so older adults. I didn't use mine until I became one. Clinical manifestations. Older adults do not always experience things the way younger people do. So they may not have pain, they may have pain, they may have a fever, they may have diarrhea, they may have UTI symptoms. They don't always respond. What's the hallmark sign if they have a UTI symptom in an older person? Dementia. And I am so surprised at how many times people go to a ER. My mom has dementia, and so the minute she gets more dementia, I'm always like to my brother, take her to get a UA. And so many times when they go to the ER, yeah. Well, why do you think she needs a UA? Because she is 10 times more dementia than she normally has. But sometimes it's a fight to get that done. But yeah, hallmarks, they will have dementia. I've seen it thousands of times. They're not as likely to pass the stone spontaneously, more likely to need surgical intervention, which is unfortunate because older persons who have to go to surgery, healing time is what? Lots of times longer, right? It sets them up for other things like pneumonia, blood clots. So what opioids are commonly administered for kidney stone? Morphine, hydromorphone, given IV. The rationale: when you have a kidney stone, it's pretty severe pain. I don't have to wonder if you have a lot of pain. Typically, people have a lot of pain with kidney stones, so that's why we treat aggressively, relieve them, and treat it. What NSAID do we normally or commonly use? Ketorolac. It has anti-inflammatory effects as well. It helps reduce swelling, and it might ease the passing of the stone a little bit. IV's fastest delivery. It's also, another reason for using IV a lot in these painful situations is lots of times they have nausea and vomiting. So the PO route's not really a good route anyway because they're not going to be able to keep it down. Any questions? Post-op pains. Well, now they had a kidney stone and they went post-op. Now they got a different pain, correct? The degree and severity of post-operative pain depends on the incision site, the surgical procedure done, the extent of the surgical trauma, the type and route of the anesthesia, and the patient's pain tolerance. All of that comes into play when you have post-operative pain. Everybody is unique, everybody responds differently, and there's so many variables that there is no recipe for knowing exactly all the answers. Assessment is how you decide what needs to be done. Pain is expected post-operatively, especially early, this first 48 hours. In my experience, I think the first 3 days is usually the worst, because that third day is when the anesthesia fully wears off. And that third day, lots of times, you get the real impact of what just happened to your body. Administer pain medicines around the clock, not PRN. Provide for a PCA for prompt relief of pain. Use a pain assessment tool. Discuss the patient's fears. Pre-op teaching is most important. Before they went in, explain to a patient going to surgery what they would expect afterwards. That's a good time to get that kind of teaching in. Main thing when we're talking about treating their pain is communicating and educating our patients to treat the pain before it becomes severe. If they have a PCA pump that they can provide prompt relief and keep that stable blood level, it will greatly improve their pain management. Also decreases their level and frequency that they're taking pain medication that way. So whenever you have a patient that has a pump, make sure you are encouraging them to press the button when they need to. The multi-modal route is the best, and stacking or using 2 or more analgesics together that have different mechanisms. That's how we attack pain the best. Instead of just upping the dose of one medicine, use 2, maybe even 3, and then some non-pharmacological routes to decrease people's pain. You get much better effective pain relief, you get a lot less side effects, and smaller doses. Other approaches, physical therapies, acupuncture, heat code application, exercise, distraction, hypnosis, imagery, relaxation techniques, relaxation breathing, meditation, art therapy, music therapy. A little warm lotion on the bottom of the feet helps too. All of these complement our pain management to manage postoperative pain better. But don't dictate to the patient what you're going to do. Ask them what works for them. Our patients have all been in pain before, for the most part. They know what works for them, correct? And we just need to come along beside them and encourage them and use what helps them instead of always dictating. Having control and feeling like you are in control goes a long way in our patients' recovery. Because if they feel helpless and out of control, sometimes that is, you already lost the game already if you don't give them that control. Nursing implications, we're going to assess their pain using their words, want to know the intensity, the location, what aggravates it, what helps it, assess their vital signs, their level of consciousness, treat incisional pain, monitor them for leg and chest pain. Why are we doing that? What are we looking for? Blood clots, right? PE, DVT. Analgesic may mask these complications. If you are so centered on their incisional pain and their post-op pain, and you're not assessing other areas, remember, acute pain is a warning that something's wrong. Warning, warning. And if we are masking that warning because we are treating another pain and not assessing another new spot, then we have basically turned off an alarm, and we're going to miss that. So always assess. Anything new that pops up, investigate it. Don't assume that you have this and you have this, so oh, that's related to that. No, it might be related, but not the way you're thinking. So always be an investigator to find out what's going on. If a person has gas pain, the opioids will aggravate it. Notify the healthcare provider to request a change in order if it's not working, if they're not getting the relief, or if your patient's becoming lethargic, the dose needs to be adjusted, okay? Anytime we give medications, they have side effects. Some of them are good, some of them are tolerable, some of them not so much, right? Opioids, constipation, they may need a laxative. You need to assess every single day what their bowel movement status is. Don't assume, ask. Because once you get them in trouble and they get an impaction or something like that, I mean, you've just added to their woes. So assess what their bowel movement status is. Nausea and vomiting, if they have that, then you are going to administer antiemetics. Assess them for sedation. Give them oxygen if they're headed south quickly. What level we're not going to let their respirations fall below? 8. Do not, if it's fallen to 8, you're stopping something, okay? I'm hoping you're doing something before you get to 8, but 8 is the warning, okay? They have to administer some oxygen. They might have pruritus from the opioids, and so they need an antihistamine. But when we're looking down this list here, what are we thinking about? We're giving opioids for pain management, right? And look at all the other sidebar things we're having to give because we are giving that. Loading up our patients, right? So there could be some drug interactions. If this is an acute issue, and this is a person who's never been in the hospital before, or never really been sick before, and all of a sudden their body's been inundated with first an injury or trauma or an illness, and now all this stuff stacking on them, do you see why they get out of sorts in the hospital? Feel out of control? They may have urinary retention and to monitor their INO, may have to insert a Foley. Not surprising that confusion might pop up, especially in that older adults. You are inundating them with lots of things. They're being inundated with stress. They're in a new place. They're not getting sleep. You're waking them up every 2 hours. Hospitals are not a good place to be, right? So expect confusion. And whatever you do, if it's an older person and they are exhibiting confusion, do not assume it's because they're old and they had dementia. That is the worst thing you can do, is just assume that, oh, well, they must be confused that way. Don't make that diagnosis. It would be a very wrong diagnosis. You always establish a baseline with their family if you need. But always, from the very first minute you're with that patient, establish a baseline of what is their cognition. Because if it goes south, it could be a lot of things, and you would miss the cues if you have not made that baseline, established that baseline. Respiratory depression, we are going to avoid that, right? We're going to stop. There's lots of warning signs before we get to respiratory depression. And if a patient gets there, it means a professional has missed a lot of warning signs. So respiratory depression should not ever happen if we're doing our assessments. We need to, if it does happen, recognize it promptly and treat it immediately. And if after you treat it, according to what the dosage is on the opioid, the naloxone might not last as long as the opioid, and it might come back. So don't just assess once, keep reassessing. If they are on a pump, we're going to always be assessing them and monitoring them. The pumps have a built-in kind of a safety because only who should be pressing the button?
The patient.
Only the patient, not a family member, not a visitor who thinks, oh, they're just uncomfortable, let's give them a little extra. Only the patient should be administering. And the safety on that is they have to be awake in order to press the button, right? So if they're asleep, they're not pressing the button, and they're not getting that extra medicine. But if they're awake and pressing the button, then I know they're not sedated just yet, okay? So that is the kind of the built-in safety, and that's why no one should be touching that button except the patient. We don't delegate anything about the pump to assisted personnel. They're to notify the nurse if the patient or family has any questions, report if they see any signs or symptoms of sedation. Also, if they witness anyone in the family pressing the button, they need to report that immediately. So, these are just some examples of the patient care pumps. They have lockout, they have maximum dose. Patient teaching is very important. Some people get a continuous infusion, just a little basal rate to help maintain their pain. Others are a bolus. Need to know if the patient's in continuous mode. Why would that make a difference if they're in continuous mode? What makes it a higher risk? Basal rate means they're getting a little bit over time, right, every hour. And if they're already getting sedated, I need to know that because they're going to get more, right, without even pressing a button. They're going to continue to get medication. So I need to know if they're in continuous mode because if they're getting sedated, that a dose has to be adjusted. Only the patient should touch the button, no one else. Monitor them every hour, document what you have seen. The nurse notes, you're going to put all the documentation about the drug, the concentration, the dose. Is it basal or is it on demand? When it started, the lockout time, the max dose, how much was infused, how much was remaining. Lots of agencies have specialized forms for documenting the pain management and the PCA documentation. Follow your agency policy. Includes a